അവർ രണ്ടുപേരും അങ്ങനെ അവിടെ ഉണ്ട്. പിന്നെ how many children you have?
I have 2.
First one I know. Second one?
Second one 6 വയസ്സ്.
അത് ശരി. അപ്പൊ അവിടെ അങ്ങ് സെറ്റിൽ ചെയ്യാണ് അല്ലേ?
ഇനിയിപ്പോ അവന് 18 വയസ്സാവുന്നവരെ ഇവിടെ നിൽക്കണം. ആദ്യം വിചാരിച്ച മറ്റവന് 18 വയസ്സാവുന്ന, പക്ഷെ അവന് 18 വയസ്സിലേക്ക് ഇവൻ വന്നു. പിന്നെ
അല്ലേ മോഹൻദാസ്, they became citizens of UK അല്ലേ? ഏതായാലും ഇടക്ക് വരാട്ടോ. ഐ വിൽ കം വൺസ്.
ഞാൻ എന്റെ ഇമെയിൽ ഈ ചാറ്റ് ബോക്സിൽ ഇടാം. അപ്പൊ
ഒരുപാട് ആൾക്കാരുണ്ട് അവിടെ, ഫ്രണ്ട്സും അറിയുന്നവരും ഒക്കെ ഉണ്ട് അവിടെ. പിന്നെ ഞങ്ങളുടെ റിലേഷൻ വരെയുണ്ട്. ഈസ് എ റുമറ്റോളജി കൺസൾട്ടന്റ്. He's there. They used to come sometimes. All are busy. അവർക്ക് ഇവിടെ വന്ന ഒന്നിനും നേരെയില്ല. എന്ത് ചെയ്യാനാ?
ഇപ്പം എവിടെയാ വർക്ക് ചെയ്യുന്നത്?
ഞാൻ ബേബിയില് വർക്കിംഗ് ബേബി. അല്ലല്ല, ഞാൻ ഡൂയിങ് ഓൺലി ജനറൽ. ഇടക്ക് വല്ലവരും വന്നാൽ കാണും, അത്രേ ഉള്ളൂ. മെയിൻലി ജനറൽ പീഡിയാട്രിക്സ്.
വീട്ടിലെ പ്രാക്ടീസ് ഉണ്ട്? വീട്ടില് പ്രാക്ടീസ് നിർത്തിയാ?
അതൊക്കെ ഉണ്ട്, അതുണ്ട്. അവിടെന്നാ ഇപ്പൊ വിളിക്കണേ.
ഇത് വർക്ക് ചെയ്യായിരിക്കും അല്ലേ? ഇതുവരെ പ്രശ്നമൊന്നും ഉണ്ടായില്ല?
ഇല്ല, നോ പ്രോബ്ലം സോ ഫാർ. അങ്ങനെ പോകുന്നു. യു മസ്റ്റ് ബി ടു ബിസി അല്ലേ, പാലിയേറ്റീവ് ആയതുകൊണ്ട്?
അങ്ങനെ ബിസി. ഞാൻ കുട്ടികളെ മാത്രല്ലേ നോക്കുള്ളൂ, അതുകൊണ്ട് അങ്ങനെ ഒരുപാട് ബിസി ഒന്നല്ല. ഒരുവിധ ഞാന് സോറി
കിഷോർ സ്പോക്ക് ലാസ്റ്റ് ടൈം. അതിന് മുമ്പ് ഞാൻ അന്ന് ഐ കുഡന്റ് അറ്റൻഡ് ദാറ്റ്.
മോഹൻദാസ് സർ പറഞ്ഞു. പിന്നെ അഞ്ജയ് ഉണ്ടായിരുന്നല്ലോ അല്ലേ? അഞ്ജയും ഞാനും ഒരുമിച്ച് കുറെ കാലം വർക്ക് ചെയ്തിട്ടുണ്ട്.
ശരി.
വിജയകുമാർ
വീഡിയോ ക്ലിയർ അല്ലേ? ഹലോ സാർ, കുറെ കാലമായല്ലോ കണ്ടിട്ട്.
ക്ലിയർ ആയോ? ചെറിയൊരു കൺഫ്യൂഷൻ, വീഡിയോയിൽ എന്തൊരു പ്രോബ്ലം ഉണ്ട്, അതാ ഞാൻ. അർച്ചന പഴയ പോലെ തന്നെ ഉണ്ടല്ലോ.
പണ്ട് ഭയങ്കര ചെറിയ മുടിയൊക്കെ അല്ലേ?
അതൊക്കെ ഒന്ന് മാറ്റി.
ഇപ്പൊ പിന്നെ മുടി മുറിക്കാൻ പറ്റൂല, ലോക്ക്ഡൌൺ ആയതുകൊണ്ട്.
ഏതായാലും മദാമ ആയില്ല.
ശ്രമിച്ചില്ല.
അതെങ്ങനെ മദാമയാവാൻ പറ്റും? ജീൻ തെറപ്പി എന്തിനു ചെയ്യണ്ടു?
അതിനിടക്ക് വൈഫ് വന്ന് നോക്കിപ്പോയി. എന്നിട്ട് പഴയ പോയി.
ഇത് ഈ സൂമിൽ തന്നെ ഓൾമോസ്റ്റ് 100 ആൾക്കാർ ജോയിൻ ചെയ്യുന്നുണ്ട് ഓരോ പ്രാവശ്യം, അതോ യൂട്യൂബിൽ കാണാണോ?
അതിൽ കൂടുതൽ വരും.
ആണോ? അത് ശരി. അപ്പൊ കണക്ഷന്റെ പ്രശ്നമൊന്നും ഉണ്ടാവില്ല അല്ലേ? എന്റെ ഇവിടുത്തെ ബ്രോഡ്ബാൻഡ് എങ്ങനെ, ഈ വൈഫൈ എങ്ങനെ ഉണ്ടാവും എന്നറിയില്ല. കാരണം ഞാൻ ഒരു പേഷ്യന്റിനെ കണ്ടിട്ട് വീട്ടിൽ പോയിട്ട് അവിടുന്ന് ചെയ്യാന്ന് വിചാരിച്ചതായിരുന്നു. പക്ഷേ അത് കുറച്ച് ലേറ്റ് ആയി പോയി. അപ്പം ഇവിടെ ഒരു ഓഫീസിലിരുന്നാ ചെയ്യുന്നത്. ഇവിടുത്തെ വൈഫൈ അത്ര ഗുണമുണ്ടോന്ന് അറിയില്ല.
കുഴപ്പമൊന്നുമില്ല,
വളരെ ക്ലിയർ ആയിട്ടുണ്ടല്ലേ?
വോയിസ് ഒന്നും ബ്രേക്ക് ചെയ്യുന്നില്ല. അഷ്റഫ് വന്നിട്ടുണ്ട്.
നിക്കി പീസിനൊക്കെ അറിയോ?
ആരാ?
നിക്കി പീസ്.
നിക്കി അറിയില്ലല്ലോ.
ഹലോ അർച്ചന.
ഹലോ അഷ്റഫ് സർ.
ഹലോ, ഒരുപാടായി അർച്ചന കണ്ടിട്ട്.
ഞാനിങ്ങനെ നിങ്ങളുടെ ഈ വെബിനാർസ് ഇടയ്ക്ക് നോക്കാറുണ്ട്. ഞാൻ ആ സമയത്ത് ജോയിൻ ചെയ്തില്ലെങ്കിലും പിന്നെ യൂട്യൂബിലൊക്കെ.
ഓഡിയോ എന്തോ പ്രോബ്ലം തോന്നുന്നു.
ഓക്കെ, സാറുണ്ട്.
കേൾക്കണ്ടല്ലോ അല്ലേ? ഞാൻ പറയുന്നത് കേൾക്കണ്ടല്ലോ അല്ലേ?
ഓ, വളരെ ക്ലിയറാ.
നന്നായി കേൾക്കുന്നുണ്ട്.
അർച്ചനയുടെ ബാച്ച് മീറ്റ് ഉണ്ടായിരുന്നല്ലോ, 25th.
എപ്പം?
പണ്ട് അന്നാണ് അർച്ചനയുടെ ലാസ്റ്റ് കണ്ടത് തോന്നിയാ.
2013
സിജ പറഞ്ഞു.
2 കൊല്ലം മുമ്പല്ലേ?
4 പേര്.
7 കൊല്ലായി.
അത് തന്നെ, ഈ 4 പേരോട് ഇറങ്ങാൻ പറയാം. റിസർവ് ഗ്രൂപ്പിനോട്
അറിയോ?
അതിനാണുള്ള റിസർവ് വെച്ചിരിക്കുന്നത്. അപ്പൊ ഇവര് റിസർവ് ഓട്ടോമാറ്റിക്കലി റിസർവ് ആവും.
എനിക്ക് പരിചയമൊന്നുമില്ല, കോഴ്സിന് പോയപ്പോൾ അറിയാന്നല്ലാണ്ട്. മറ്റേ ഫിയോണനെ കുറച്ചും കൂടെ നല്ലോണം അറിയാം. ഫിയോണ റോളൻസൺ അവരുണ്ടായിരുന്നോ? ഉണ്ടായിരുന്നില്ല അല്ലേ?
We just saw some of her videos.
I see. Yeah. അജിത് ജോയിൻ ചെയ്തിട്ടുണ്ട് തോന്നുന്നു.
സ്റ്റാർട്ട് ചെയ്യാനായോ?
2 മിനിറ്റ്
കൂടി.
അർച്ചന, ഹലോ. അർച്ചന.
ഹലോ സർ.
അർച്ചന കുറെ കാലത്തിന് ശേഷം കാണുന്നു.
ഞാൻ അന്ന് ഐ തിങ്ക് 2013 അന്ന് അജിത് സാറിനെ കണ്ടിരുന്നു, മോഹൻദാസ് സാറിനെ കണ്ടിട്ടുണ്ടായിരുന്നില്ല.
അല്ല, എന്നെ കണ്ടിരുന്നു ഇല്ലല്ലോ.
ഞാൻ അവിടെ യൂണിറ്റിലൊക്കെ വന്നില്ലേ? എനിക്ക് യൂണിറ്റ് ഒക്കെ കാണിച്ചു.
2013 2013. ഓക്കെ. സുഖമായിട്ടിരിക്കുന്നോ?
കുഴപ്പമൊന്നുമില്ല, അങ്ങനെ പോണു. അവിടെയോ? ബോസ് എവിടെയാണ്?
സുഖം. ഇവിടെ കോവിഡ്. ബോസ് ദുബായിലാണ് ഇപ്പൊ.
ശരി.
ദുബായില് ഇപ്പൊ ഇവിടെ ഇപ്പൊ കോവിഡ്. ഇപ്പൊ ഞാൻ ഹോസ്പിറ്റലിലാണ്. റൂം പണ്ട് റിയാസ് സാറൊക്കെ ഇരുന്ന റൂമാണ് ഇത്. ഇഫ് യു വാണ്ട് ടു സീ ദ റൂം ഐ വിൽ ഷോ യു.
എന്റെ റൂം അല്ലേ?
അതെ.
ഞാനൊരു ബോറോഡ് ഓഫീസിലായിരിക്കണം, അതുകൊണ്ട് IAPന്റെ ബാക്ക്ഗ്രൗണ്ട്.
ഓക്കെ. ഏത് യൂണിവേഴ്സിറ്റിയിലാണ് അപ്പൊ അവിടെ?
ഞാനിവിടെ ഷെഫീൽഡ് ചിൽഡ്രൻസ് ഹോസ്പിറ്റൽ എന്ന് പറഞ്ഞിട്ട്.
ഷെഫീൽഡ്സ്. ഓക്കെ.
യൂണിവേഴ്സിറ്റി ആയിട്ട് ഒരു എന്താ പറയാ, ഓണററി അഫിലിയേഷനേ ഉള്ളൂ ഷെഫീൽഡ് യൂണിവേഴ്സിറ്റി ആയിട്ട്. അത് ഷെഫീൽഡ് ചിൽഡ്രൻസിലെ എല്ലാ കൺസൾട്ടൻസിനും വേണമെങ്കിൽ ഓണററി അഫിലിയേഷൻ എടുക്കാം.
മോനോട് കൺഗ്രാജുലേഷൻ പറയും. മോന് കഴിഞ്ഞില്ലേ?
അവനിപ്പോ ഫസ്റ്റ് ഇയർ ഇന്റേൺഷിപ്പ് കഴിയാനായി. ഇനി ഒരു കൊല്ലം കൂടെ ഇന്റേൺഷിപ്പ് ചെയ്യണം.
ഏത് കോളേജിലാണ്?
അവന് പഠിച്ചത് ഇംപീരിയൽ കോളേജിലായിരുന്നു. പിന്നെ ഇന്റേൺഷിപ്പ് ഏത് ഹോസ്പിറ്റൽസിൽ എവിടെയാന്ന് വെച്ചാ വേറെ പോയിട്ട് ചെയ്യാം. അപ്പൊ അവൻ ഇപ്പൊ പോർട്സ്മത്ത് എന്ന് പറഞ്ഞിട്ടൊരു ഹോസ്പിറ്റലാണ് ചെയ്യുന്നത്.
മോഹൻദാസ്, why don't we start? 5:30 ഇല്ലേ?
സ്റ്റാർട്ട്.
അഷ്റഫ് ഒന്നുണ്ടോ?
അഷ്റഫ് അതാ.
അജിത്ത് സിജ ആയിരുന്നു. സിജ ആയിരുന്നു.
ഞാൻ വിളിച്ചു. ഓക്കെ.
ഡ്യൂട്ടിയാ?
പിന്നെ പറയാം. വിജയകുമാറാണോ? ഓക്കെ. മോഹൻദാസ്, ഐ തിങ്ക് വിൽ സ്റ്റാർട്ട് അല്ലേ? 5:30.
അതാണ് ജോയിൻ ചെയ്തോളാം. സ്റ്റാർട്ട്.
ഗുഡ് ഈവനിങ് ആൾ. നമ്മുടെ പീഡിയാട്രിക് മാസ്റ്റർ ടോക്കിൻ്റെ ഇന്നത്തെ സെഷൻ ഡോക്ടർ അർച്ചന സോമനാണ് ഡീൽ ചെയ്യുന്നത്. അർച്ചന സോമൻ നമ്മുടെ കോളേജിലെ 30th ബാച്ചിൽ പഠിച്ചതാണ്. 32nd ആണോ? ഓക്കെ. 32nd ബാച്ചിൽ പഠിച്ചതാണ്. അതിനുശേഷം നമ്മുടെ ഡിപ്പാർട്ട്മെൻറ്റിൽ നിന്ന് IMCH വരുന്ന PG കഴിഞ്ഞതിന് ശേഷം കുറേ കാലങ്ങളായിട്ട് UK വർക്ക് ചെയ്തുകൊണ്ടിരിക്കുകയാണ്. കുറച്ച് വർഷങ്ങളായിട്ട് അർച്ചന മെയിൻലി പാലിയേറ്റീവ് കെയർ ഫീൽഡിലാണ് വർക്ക് ചെയ്യുന്നത്. അതുകൊണ്ട് തന്നെ നമുക്ക് നമ്മളോട് ഇന്ന് സംസാരിക്കുന്ന ടോപ്പിക്ക് മെയിനായിട്ട് വളരെ ക്രോണിക് എന്താ പറയുക, ഇൻക്യൂറബിൾ ആയിട്ടുള്ള ഡിസീസസ് അങ്ങനെയുള്ള കുട്ടികൾക്ക് ഇൻറ്റൻസീവ് കെയർ ഒക്കെ പ്രൊവൈഡ് ചെയ്യുമ്പോഴുള്ള കൺഫ്യൂഷൻസ്, നമ്മൾ എത്രമാത്രം കെയർ കൊടുക്കണം, അല്ല എന്തൊക്കെ തരത്തിലുള്ള കെയർ കൊടുക്കണം, അത് നമുക്കും വലിയ കൺഫ്യൂഷനുള്ള കാര്യങ്ങളാണ്. നമ്മുടെ ICUലൊക്കെ മാസങ്ങളോളം ചില കുട്ടികളെ വെന്റിലേറ്ററിൽ, അതേസമയം വലിയ പ്രതീക്ഷയൊന്നും ഉണ്ടാവില്ല, രക്ഷപ്പെടുന്നുള്ള പ്രതീക്ഷയൊന്നും ഉണ്ടാവില്ല. പക്ഷെ പല പല എത്തിക്കൽ കൺസേൺസ് കാരണം നമുക്ക് ഒരു ഡിസിഷൻ എടുക്കാൻ പറ്റാറില്ല. അപ്പോൾ UK ഇങ്ങനെയുള്ള ഏരിയയിൽ ഇങ്ങനെയുള്ള സിറ്റുവേഷൻ എങ്ങനെ ഡീൽ ചെയ്യുന്നു എന്നൊക്കെ അറിയുന്നത് നമുക്ക് നമ്മുടേതായ ഒരു പോളിസി ഉണ്ടാക്കുന്നതിന് ഹെൽപ്ഫുൾ ആവുന്നുള്ള ഒരു തോന്നലിലാണ് അർച്ചനയോട് ഇന്ന് ഈ ഒരു വിഷയത്തെ പറ്റി സംസാരിക്കാൻ ആവശ്യപ്പെട്ടത്. നമ്മുടെ ഇൻവിറ്റേഷൻ സ്വീകരിച്ച് വന്ന അർച്ചനയെ സ്വാഗതം ചെയ്യുന്നു. അതുപോലെ ഈ ഇന്ന് നമ്മളോടൊപ്പം ചേർന്നിരിക്കുന്ന നമ്മുടെ സീനിയർ പ്രൊഫസേഴ്സായ ശശിധരൻ സാറ്, അതുപോലെ മറ്റ് ഡിസ്റ്റിങ്വിഷ്ഡ് മെമ്പേഴ്സ്, HOD ഡോക്ടർ അജിത്ത്, IAP കാലിക്കറ്റ് പ്രസിഡന്റ് അഷ്റഫ്, സെക്രട്ടറി നിഹാസ്, എല്ലാവരെയും സ്വാഗതം ചെയ്യാൻ ഈ ഒരു അവസരം ഞാൻ ഉപയോഗിക്കുകയാണ്. അടുത്തതായിട്ട് ആരാ പറയുന്നത്? അഷ്റഫ്.
വോയിസ് കുറച്ച് ക്ലിയർ അല്ല.
കണക്ഷൻ പ്രശ്നമുണ്ട് തോന്നുന്നു കേട്ടോ അഷ്റഫ് സാറിന്റെ.
Okay, Ajit.
Thank you, Archana, for accepting our invitation. It was really great seeing you. I'm really happy. And Archana, എനിക്ക് ചെറുപ്പത്തിലേ അറിയാം, ലൈക്ക് സ്കൂൾ, ഞാനും അർച്ചന ഏകദേശം ഒരേ സ്കൂളിലാണ് പഠിച്ചത്, കേന്ദ്ര വിദ്യാലയ number 1 East Hill, and he was the topper from there onwards, knowledge studies and pediatrics. ഇവിടെ വന്നപ്പോൾ one of the best student who has passed out from Calicut Medical College and from the Department of Pediatrics, and she is a person who has she a lot of convictions, a lot of what you call, that's why she's taken to this palliative care. Maybe Lulu Madam's path, Lulu Madam inspired ആണെന്നോ അറിയില്ല. Lulu Madam might have inspired her, or maybe she was initially in hemato-oncology, I think, and then maybe from there she is now in palliative care. And always this question arises in most of our minds, when how long to, I mean, how strong you have to push a child in oncological services. For example, they may have 1 or 2 relapses, and then how the parents might be willing to take the risk, or sometimes the parents may not be. Sometimes the physician will be very much attached to the child, so that he will take all the risk and try to pump in more aggressive chemotherapy or whatever treatment, trying to save. And I mean, it's always a gray zone where when to stop and when not to go beyond a certain limits. Even I have faced these questions when I was dealing with some patients with leukemias and malignancies, and it's really heartbreaking and really painful for the decision to be made when not to give, and when you have to go for palliative care. And palliative care is not at all what you call a care which has to be what you call considered less than the chemo, what you call less than the other modes of therapy. Lunumada po parayna pole, it is one of the very important mode of treatment. Palliative care in pediatrics has a great role, and I think Dr. Archana will enlighten us on where to stop the what you call line, or when to go to palliative care and all these things. And I invite Dr. Ashraf, our IAP president, to say a few words.
Dr. Archana, very happy to see you on this platform. As Mohandas said, Dr. Archana belongs to 32nd batch. Know her from her student life onwards. Very dynamic student leader she was at that time. Later, she interested in the field of palliative medicine. I think Lulu Madam is also there. Riya sir is there. CK sir is there. Newborn പലപ്പോഴും CK sir പണ്ട് പറയുമായിരുന്നു lot of congenital anomalies നമ്മളൊക്കെ സ്റ്റുഡൻ്റ് ആയിരിക്കുന്ന കാലത്ത് അല്ല വല്ലാതെ ആക്റ്റീവായിട്ട് റിസസിറ്റേറ്റ് ചെയ്യേണ്ടതാണ്. പക്ഷെ nowadays lot of ethical concerns are there, as Ajit rightly pointed out. So this is whether I have to say whether it is interesting. I don't know. Anyhow, this title is very interesting. Life-sustaining treatment for children with life-limiting condition. How far is too far? Over to you, Dr. Archana.
Thank you very much, especially for all your kind words. ഞാൻ ഇങ്ങനത്തെ ടോക്സ് കുറെ ഇടക്കിടക്ക് ചെയ്യുന്നതാണ്, പക്ഷെ I've never felt so nervous doing it. I don't know. It's really daunting to come back and talk to people who have actually taught me and sowed seeds of pediatrics and medicine in general and humanity in more general in me, and therefore it's quite daunting. I'm not entirely sure that I will be able to provide all those answers. These are gray zones for questions everywhere in the world. There are no easy answers, and often what I see is there is no right or wrong answer, and you can't determine what the right or wrong is for a child and a family beforehand just by studying their condition or their numbers or whatever, unlike in other specialties. And something that I also want to emphasize is that as you all pointed out that Lulu Madam has been trying to emphasize as well, palliative care is very much a specialty in its own right, and it's an integral part of care for children who might have a life-limiting condition. It doesn't mean giving up care. And I was I was talking to him about how we have to put in so much more resources to a child and the child's family here in the UK when we change the focus from curative care to palliative care. The resources and the treatments put in are much more than what you would get in a hospital, actually, and because it's much more ongoing. And therefore, something I really hate is saying withdrawal of care, because we're not withdrawing care, we are actually putting in a lot more care. So I'll try to share my slides. One of the things I wanted to say is, I know that some of these things might come across as abstract because, especially in the medical college situation, you might not be used to the things that I am talking about. And if you please feel free to stop me and discuss at any point. If you want me to do it in a less abstract way, more applicable to the context there, I'm happy to do that. The other thing is, if I would appreciate interaction if possible at all. And if anybody ആർക്കെങ്കിലും മലയാളത്തിൽ സംസാരിക്കണം എന്നുണ്ടെങ്കിൽ മലയാളത്തിലും we can have the discussion. It's not a problem. So I hope this will work. Right. So the outline of my talk will be to first define what life-limiting conditions are and what kind of conditions are we talking about. A bit about the general ethical principles that underpin any decision-making in medicine, not just withdrawal or withholding of life-sustaining treatments. And so that applies universally. It's universally accepted doctrines. But what I am used to is working with the framework that's accepted in the UK for withholding and withdrawing life-sustaining treatment. A bit about advanced care planning, because planning in advance makes a lot of these decisions a lot easier. If you can walk the journey with the family and the child from as early as possible, it makes the ultimate decisions much easier. I'll try to present some real life cases to prompt discussion and may or may not be applicable in the context there, but I think there will be some applicable aspects at least. And then I'll list a few practical suggestions and resources, which I won't go into much detail, but I can send you links to, etc., if people find that helpful. So any condition that is likely to shorten a child or young person's life, despite appropriate treatment being given, is a life-limiting condition. So that itself says that it doesn't mean that a child is going to die imminently or certainly. So even if a child might be cured or might have a much more prolonged life, they still could benefit from the principles of treatment for conditions that are life-limiting. And the palliative care is both practice as well as the principles, the ethos of care. And I think both those should be applicable and available to children and families right from diagnosis, as I said before, not just at the very end when we are we're struggling keeping the child alive. There are numerous definitions and guidelines and care pathways and standards. And in the UK, we go by mainly the standards and care pathways put together by both the Royal College of Pediatrics and Child Health and an organization called Together for Short Lives. So they work together to produce guidelines, etc. And how they classify life-limiting conditions, they classify them into 4 categories. And category 1 is actually life-threatening conditions. So curative treatments might be feasible, but may fail. So palliative care might be necessary when either the treatment fails or during an acute crisis, irrespective of the duration of the threat to the child's life. And sometimes in such children, the need for palliative care ceases when remission or cure has been achieved. And of course, the main example would be treatable cancers, but also in organ failures where transplants are available, this would apply. So that's a trajectory in a curable malignancy. So if you get a diagnosis, usually, especially in the hematological malignancies, your health deteriorates initially with treatment, but then comes back up with remission, and you might need palliative care at that point, or when there is a relapse, etc., or even during that period when there's the uncertainty and there are symptoms to manage. Category 2 is becoming less of a problem for us here, because this is a category where premature death will happen at some point, but there might be long periods of normal life possible with quite intensive treatment. And the examples are cystic fibrosis and Duchenne muscular dystrophy, and both of them people are outgrowing childhood, and even Duchenne muscular dystrophy, very soon we might have treatments available that might prolong their life much further. And that would be the trajectory. So you have a very good baseline for a long time, and then you get acute blips where you might not come back to the previous baseline, and there is a downward trend in your baseline. Category 3 is more problematic. These are the progressive conditions where curative treatments are currently not available, and treatment is exclusively palliative from the beginning. But again, that might extend over many years. And more recently, this should include even when experimental treatments such as gene therapy and bone marrow transplants, etc., are available for some of these conditions. The examples are the inborn errors of metabolism and causing incurable neurodegenerative conditions. So that's their trajectory. I am going a bit fast. If you want me to slow down, I can do. It's just because then we can cover a little bit more breadth of the subject. The category 4 are probably the commonest that we here deal with. I think it might be similar in the context there as well. These are the original pathology is irreversible but non-progressive. but the morbidity to the child is progressive, and therefore the child becomes more and more susceptible to health complications and the likelihood of premature death. So these are the children with cerebral palsy and or severe spinal cord injury. So although the initial pathology is not progressive, the longer they live, they become more vulnerable to acute complications as well as gradual deterioration in their general health. And that might be what the trajectory looks like. So in the UK, we are becoming increasingly aware of the need for palliative care services. And this is largely backed by some prevalence studies done by Lorna Fraser and colleagues. And they demonstrated an almost doubling in the prevalence over 8 years from 2001 to 2008, and then again, a further doubling to 2017 to 2018. And currently the prevalence is estimated to be 66.4 per 10,000 children. This is 0 to 19. So 66.4 per 10,000 0 to 19 children are thought to be living with a life-limiting condition. It's very useful data to influence authorities to provide the services, because although we talk a lot about this, we still don't have palliative care services available as much as we would like, or even a fraction of what we would like. There aren't many consultants, there aren't many nursing teams available to provide the care. And I was talking to Mohan Dasar about this, and it might be possible to do some studies there to estimate the prevalence. And I was made aware of the disability survey census that was conducted, but it might be also useful to look at a limited geographical area to see what the granularity of that disability or life-limiting condition prevalence is, and that might help us design and develop services. So coming to deciding what is right for a patient or not, be it in a life-threatening situation or in any other situation, the basic principles are these. So these were first described in 1979 by Beecham and Childress, and so beneficence and non-maleficence. So as doctors, what we do should be beneficial to the patient. And if we know that we're not going to do benefit, then we shouldn't be doing it. But equally, side by side, there should be non-maleficence. So we shouldn't be causing harm knowingly. So that, I don't think, needs more explanation. It's self-explanatory. Autonomy is another concept which probably is not as, professionals are probably not as acutely aware of that concept in the East, unlike in the West. So my health is my right, and what I do, what treatment I have or not is my right to decide. You as a health professional present me the evidence and I make the decision whether I should have that treatment or not. And that's where we get into slightly muddy waters when it comes to children. The fourth aspect of the four basic principles of bioethics is justice. And justice is, again, something I think which probably justice is something which does just the opposite, because it's probably a bit more relevant to a resource limited context than to a resource plenty context, especially with distributive justice. So justice can be divided into three groups. One is rights-based. So my right to live, my right to enjoy life, etc., is rights-based justice. Legal is the law of the country where you are. What does the law stipulate? So in Switzerland, you can have euthanasia. In most other parts of the world, you cannot have euthanasia. That's illegal. So that's legal justice. What is more interesting to discuss in the Indian context is the distributive justice. So if I am doing a less than extremely beneficial treatment to a child, and the child is not likely to benefit from it, am I depriving 9 other children from a treatment which might actually benefit them? And I think we need to be very conscious about that when resources are limited. That does apply in any country, even here, but I think it's probably less in your face here when you're talking to, especially because we have much fewer children here because of the population numbers. And whenever we're talking about these 4 principles, we also need to think about the scope of applying these principles. As I said, autonomy, is there a scope of applying autonomy in children, or distributive justice, is there a scope to apply that principle and discuss that in that particular context? And it's very easy to interpret these concepts simplistically and think that that's an answer to all ethical dilemmas. It's not. When you put them into practice, it becomes very clear that these are not as simple as they look, especially because one might compete with another. So you might think something will do benefit, but it might also do harm, and then you have to balance those. And benefit might compete very much with autonomy, or non-maleficence might compete very much with autonomy. Somebody might want something that's not actually beneficial to them. So where do we draw the line? Which one trumps the other? And the basic principle is that they're all equally important. One doesn't trump the other, and it depends on the situation. So to interpret those in particular situations is less simple than it sounds on paper. So I find this useful. This is an interpretation of that from Rannan Gillen. He says, the provision of health benefits with minimal harms in ways that respect people's deliberated choices for themselves and that are just or fair to others, whether in the context of distribution of scarce resources, respect for people's rights, or respect for morally acceptable laws. So just what we discussed. Oh. So it becomes much more complicated when we ask the question of autonomy in children. Who decides for children? Who are the right people to decide? Are the children themselves competent enough to make tough choices and decisions? And as per UK law, there's no age defined. So there is, well, over 18, you're an adult and you can make your decisions if you are thought to be mentally able. So if you have capacity to make the decisions. But below 18, it's very nebulous. What age are they able to make those decisions? So a child who suffered acute leukemia or another kind of cancer from the age of 5 or 6, by the time they are 12 or 13, they would have had a very good understanding of their disease, their treatment, and the world in general. And so they might be able to make those decisions for themselves. Whereas another 13-year-old who either has not had the developmental maturity or has been very protected socially and in the family and suddenly develops an illness, they might not be able to make that decision. So it's very much dependent on the child. One thing which is very much misinterpreted by parents, especially in Western cultures, I think, is that parents have the ultimate authority, that they can refuse necessary treatment because of, I don't know, cultural or religious beliefs, or that they can demand medically inappropriate treatments. And it is very clear from interpretations of the law as well as the frameworks that that's not the case. So then who makes the autonomous decisions for children? Nobody can. What we have to do is work out the best interests depending on the particular child and the particular condition, and the experts on the child's condition makes the decision. And when I say experts on the child's condition, it can be easily misinterpreted as if it's a renal condition, the nephrologist, or if it is a cancer, the oncologist. That's not what I mean, and I'll go into it in a bit more detail. So who are the experts? sorry, just to go back a step, these are the guidances and the legal statute behind what we do, which guide what we do. So there's a GMC guidance from 2002, the RCPCH guidance, which came out initially in 2004, was updated in 2014. And then the law that allows us to do these things is based in the Children Act in 2004. Now, what we're talking about is situations where withholding or withdrawing may be appropriate. It doesn't mean that in these situations treatment should be withheld or withdrawn. So we're talking about who the experts are in various situations. So according to those guidance, the guidance on the previous slide, you can think about withdrawing or withholding treatment when there is, of course, when there is informed, competent refusal of treatment. And a parent cannot make informed, competent refusal of treatment on behalf of a child, as I said already. But a child may or may not be. Sometimes courts allow children to do that, but that is very, very rare. Adults can. Children usually can consent to treatment without the parents consenting, but they cannot usually refuse treatment. So that's out of the question for our discussion. And if it does come up, it's for the courts. But the other two categories are limited quantity of life and limited quality of life. So limited quantity of life are when either there is brain death, so you've had a very bad road traffic collision and head injury or something like that, and they're brain dead, and they're kept on a ventilator. So you can withdraw treatment, withdraw treatment. Or imminent death. So the child is on maximal intensive care, maximal ventilator support, maximal inotropes, etc., and the child is developing multi-organ failure. In such a situation, death is inevitable imminent. And even if you then do CPR, you know that either you don't get the heart rate back at all, or if you do, the child's going to arrest again. So that's the imminent death situation, and you don't have to do CPR in that situation, or you can withdraw intensive treatments. Inevitable demise is a little bit more gray, but it's usually to do with terminal cancers or untreatable brain tumors. So whatever you do, the child is going to die sooner rather than later, and then you can decide whether you should withhold intensive care or withdraw. So if you look at that, we talked about all those. I think it's fairly obvious that the experts are the professionals. So we are the ones who can say, yeah, your son is brain dead. There's no way he's going to live. Or all his organs have failed, and regardless of us attempting CPR, we won't be able to get the child back. Or this cancer is going to kill her in a few weeks or months. But how about the quality of life? So the guidance tells us that you can withhold or withdraw when there is evidence of limited quality of life. And the three categories of that are when the burdens of the treatment outweigh the benefits that the child will get from the treatment. So the quality of life is so poor that the burdens of treatment outweigh the benefits, or the burdens of the illness itself. So if you've got a very painful condition, or somebody in chronic constant dystonia or whatever, and you're not going to be able to treat them to take away that burden of their illness, then you might be right in thinking that about withdrawing and withholding. And the other category is inability to derive benefit. So the burden of treatment might not be too much, the burden of the illness might not be too much, but the inability to derive benefit is almost non-existent. So that's the persistent vegetative states, where you are talking about withdrawing nutrition and hydration. Mostly it's the persistent vegetative states. So when this is the situation, how do we make the judgment, and who makes the judgment whether the burden of treatment is too much for the child, or whether the burden of the illness makes it too distressing for the child to remain alive? That is not that easy. I wouldn't be able to hand on heart say that that's too much, that burden is too much for that child, especially because I will only be seeing a snapshot of the child, and I don't know what their quality of life is otherwise, and how much they would gain from being resuscitated or kept alive. So these are very value-based judgments, very subjective. And you could argue that parents know their child best, and often they do, very often they do. Parents know the child's wishes, even if in situations where children have never been able to voice their wishes and their preferences, parents have learned to interpret them. They also know what thresholds they have for tolerating interventions. But sometimes it is their perception of the quality of life and their perception of their child's quality of life. And that is where they might confuse their quality of life with the child's, or their needs with the child's. But what I always insist is that we have to respect this expertise in parents and treat them as our colleagues in making those decisions. But are they always best judge? As I said, sometimes they're not. Sometimes they're so engrossed in the minutiae of doing their nasogastric feeds and tracheostomy cares and medications and things like that, they can't see the wood from the trees. And if they stepped back, they might have a different view of things. And it's easy for parents to put their needs and interpret their needs to keep the child alive as a child's needs. Sometimes religious beliefs cloud this judgment, and I have seen the same religious doctrine being interpreted in two extremely opposite ways in the same week. So one family has told me they both have the same, they believe in the same religion, and one said, this is God's fate, God's decision for our child, and so we don't want to go against that, and we just do whatever, however much he can take and not push too much. And the other family says, but God wants us to keep trying until his heart stops, so we don't want to give up on it. So it's interpretations. Another thing that you probably have heard is the media, the furore the media cause, especially in the UK, over these decisions. So that's where I think advanced care planning is very important. And that's where it's important to know the child and the family from the time of diagnosis, and they have an honest and open understanding of the diagnosis and the prognosis. And the professionals try their best to find out about the goals of the family, their values, their spiritual and social values, their priorities, and what their wishes are for the child and for them as a family. And then we start working on best interest-based planning from very early on, when the child is well, reasonably well, and plan for predictable and unpredictable worsening, including, but not just, resuscitation plans. And for every such best interest-based decision that we're making, we have to balance the benefits versus the burdens. Is this the benefit that we're achieving from non-invasive ventilation, for example, going to be too much of a burden to the child? Is that going to cause the child too much distress? Is that going to tie the child to the bed and the bedroom and prevent the child going out and doing things that they and their family might otherwise want to do? But there are lots of benefits. So as I said, it's a prompt to always focus on the child's best interests. In a way, we're giving control to the family and the child, ensuring their wishes. So if we have planned these very early on, if we've started the planning, some families will be able to decide and achieve the place of death that they want the child to be. Whose arms should the child die in? Where should they be? Should they have done this beforehand, that beforehand? So they have a bit more control rather than dying with failed resuscitation attempts on an intensive care table. We also will not be making hasty decisions when a child comes in to our emergency department. When these plans have been made and the parent brings in a copy of the plan, it's much easier for the emergency department staff to know what decisions, what treatments might be appropriate and what might not be appropriate for the particular child. Therefore, we're also able to improve symptom control. So we have a very major focus on keeping the child comfortable and pain-free and symptom-free at all times, as much as we can. We also can coordinate care because often these children will have 101 specialists and specialties involved, and they have to repeat the story to every one of them, and there's no coordination between them. And that's where palliative care plays a huge role in coordinating that care and making sure that everybody has an understanding. It also gives the family time to prepare and obtain emotional support wherever available. But there are numerous challenges. And as you all know, clinical uncertainty is a major part of it. Whatever diagnosis, whatever specialty, we can't tell for certainty, usually this is going to happen. There's always, this might go this way or that way or that way. And therefore we have to plan for all those. Some families might interpret when I say we need to do an advanced care plan that we're trying to take away their hope. But what I always emphasize is that we have to hope for the best. We have to prepare for the worst and plan for everything in between. And sometimes, especially this applies to young adolescent patients who are competent, they want to focus on the present. They don't want to think about what happened, what if I have a severe chest infection 2 years from now? I don't want to think about that. But very often what I find is it's clinicians' discomfort in raising these issues, their ethical uncertainties. Most of us are not trained to have these discussions, and we don't have the time or the resources to provide continuity of care. So I don't know how much time we have. I will go through a few. If I'm running out of time, please do stop me. But I thought it would be useful to go through a few cases. So this is an 18-month-old girl who was born with congenital CMV and severe global developmental delay and seizures. She has an upper airway obstruction, the cause of which we are yet to find out. And she has also severe gastroesophageal reflux. So this is where I would actually like some interaction, if especially the trainees at Calicut Medical College, if anybody has got any contributions about what your priorities would be in your discussions with the family. If you come across, if this child came to you for, I don't know, treatment of a chest infection, but she's not that unwell, would there be anything that you would be talking to the family about? Does anybody want to, even if it's in the chat box? Otherwise, I can just carry on. I don't know what I should do. Okay, so in this child, the things that I'd be thinking of are, did anybody want to contribute? No, okay. Yes, go on.
Maybe identifying the issues, specific issues.
Such as?
This child has seizures control of seizures, how to improve the GER, which can be treated easily, like GER and treatment of seizures or and what we can do for the development delay with it.
Absolutely. So that would be my focus too. So usually when people are talking, let's get the palliative care consultant involved or the palliative care team involved, what even professionals, what they think is we're going to say, stop all treatment. We don't do that. And very often families fear that when they meet me, I'm going to say, no, let's stop all treatment. Your child's not worth saving. But that's not at all the idea. So in this child, the mom knew that she has a shortened life. So my work was half done because she already knew all the prognosis and the complications that she could have. And she was not, I think if you're not talking, if you could mute your mic, otherwise there's a lot of echo. So, and she was already of the understanding that this child wouldn't benefit from prolonged intensive care admissions or CPR if she had to rest, etc. And she had been NG fed, nasogastric tube fed for more than 6 months, and there had been talks about a gastrostomy and fundoplication, and I don't know. Okay. And I think people thought, oh, she's palliative, so we shouldn't be doing that. But so I had to actually use a little bit of force to make colleagues accept that no, fundoplication and gastrostomy will make this child's quality of life better. We're not doing that to keep her alive for however long. We're doing it to relieve her symptoms. And similarly, whether a trial of non-invasive ventilation would help with her airway, and because she was suffering severe respiratory distress because of her upper airway. And it took some convincing of specialists to say, yeah, this might not be an unacceptable thing to try, because with NIV, you're not actually going to do anything irreversible. Mom did get a suggestion from Facebook that she should have a tracheostomy, and she raised the question, and we discussed it very openly, and what the burdens of a tracheostomy are, how she will end up in hospital for a few months post tracheostomy, and how that might make her problems more difficult and reduce her quality of life. And she was very much in agreement with that. And therefore, we've decided that tracheostomy won't be in her best interest. So that's where I would be balancing those benefits and the burdens. But we've also made plans for worsening seizures, worsening respiratory infections, and the possible cardiorespiratory arrest. And this mother clearly agrees with us that CPR would not be a good thing for her. But there are more subtle things, and I think this might not be all that applicable in in the Calicut context. I'm not entirely sure. So this was a child who was born with trisomy 18, which was diagnosed only after he was born, and he was shown to have a large VSD, but nothing incompatible with life. They're very sort of educated, well-spoken parents, and they always thought that they would never cope with a disabled child. And one of the things that early on the neonatologist had spoken to them about was not putting in too many interventions, do not resuscitate, etc., etc. And they felt that that meant that they could decide when the child should die, in the sense that that child was being fed through a nasogastric tube, and their understanding was that I would agree that, yeah, we don't need to feed this child because he's got a condition that will make him really disabled. So I could just stop the feed and let him die. I did a lot of soul searching, and I spoke with lots of colleagues throughout the country and even abroad. And we felt that as long as the child wasn't burdened by the nasogastric feed, so as long as the child didn't develop GI failure or pain, visceral pain and things like that, that were not treatable, we didn't see a reason. The burden of feeding was on the family, not on the child. And therefore, we made a decision to continue feeding. And the child eventually died of a bronchiolitic episode. So this is another child, a 10-year-old whom I only met when she was about 9.5. With a chromosomal anomaly, and she is spastic quadriplegic. She's got scoliosis, bilateral hip dysplasia, all the things that she goes with spastic quadriplegia. She has gut failure, so she's on total parenteral nutrition. She is on nocturnal NIV because she has some kind of sleep apnea. She also has developed scleroderma with frequent painful flare-ups. Her hips are painful despite multiple surgeries. Her spine is also painful. Her gut is painful. Everything is painful. But I'm just a little bit disappointed that these discussions weren't put in place before, did not happen before these interventions were put in place. And it's easy for me to look back and say you should have done that, and I don't know what happened, but this is the kind of scenario that we try to prevent by early discussion. So when we discuss, is nocturnal NIV the right thing for the child? Is TPN the right thing for the child? Are repeated surgeries the right thing for the child? I think we should have had those discussions at every point when we did those. But whatever framework you use, whatever you do, or however well trained you are in communication, these things happen all the time, especially in the UK. Talking to European colleagues, it doesn't seem to happen as frequently in other countries there. So this is a news report saying in 5 years, there were 22 cases that the court had to decide on limiting life-sustaining treatment in seriously ill children. This is not ideal. But how, whatever the disagreement, it's almost always every one of us, the colleagues in the team, be it the parents or the professionals, have the child's best interests at heart. But it's how we interpret those best interests that differ. I don't think any parent or any professional makes these decisions or pushes for these decisions with malice. So what will help in making these discussions smoother? As I said, really honesty. And this is where I think I've had some conversations with colleagues in India. I don't know if we're still open to having full honest conversations with families, and time doesn't allow that, but also understanding and various cultural factors. People, I don't think, still want doctors to tell them things as they are. But it is really important, and I wouldn't go back to holding back information from families. And early introduction of the concepts of palliative care and advanced care planning. Multidisciplinary team working, as many people as you can get to work with you and with the family. And that's more easy said for me than for you guys, but it's difficult in practice here too, not to the same extent. Professionals need training in communication skills. How do we communicate with families? And communication is not just talking. Communication is much more listening and hearing their concerns and responding appropriately. And it's very useful to have a key worker for the family who will act as their advocate and provide continuity. So I mentioned this quotation that the sentence that I use, but also I think it's very important to avoid strict differentiation between palliative and curative phases of a child's journey, because you could go back and forth and it could go parallel, and it's parallel planning. We'll hope for the best, but plan for everything that's less than best. And these, I won't read these out but it's just to emphasize that these are medical decisions. So in here, what professionals very often, where they fail is saying to the family, do you want your child ventilated? I'd say to them, you don't ask them, do you want antibiotic? You give them the antibiotic, and you don't give them the antibiotic if the child's got an infection that's treatable with an antibiotic. It should be the same with these, but you explain to them, this is why we're not doing this. This is because we don't think the child will benefit from ventilating, or we think the child's will benefit from ventilating, and therefore we're going to do it. There should be an understanding and agreement, but it is not a parental decision, it's a medical decision. And I think if that becomes clear not in a paternalistic way, not saying that I know the best, but having taken into account your expertise on the child's quality of life and the child's personality and everything else, and having taken into account their medical situation, my professional decision is that the child will not benefit from ventilating. And it's important to talk very clearly when the child's coming to the end of their life and what might happen as well. And I just really hate it when my colleagues say this child is palliative. No child is palliative. The child might need palliative care, and going down the palliative route and withdrawing care, etc., are really annoying phrases. These are some helpful resources. So this is a document that we currently use. This is from a collaborative called Child and Young Persons Advanced Care Plan Collaborative, and it's available to download on their website. And it goes through all of the child's demographic information, contacts, etc., etc. That's what it includes. So their diagnosis, their wishes, and then emergency medical management plans. So there is a section for management of significant deterioration, but non-arrest situations. So if you have a significant respiratory infection or a major seizure or something like that, what would you do? Would it be appropriate to give the child face mask oxygen? Usually it's a yes. I've never ticked no for that, but is emergency transfer to hospital appropriate? Is intraosseous access appropriate? Is admission to intensive care appropriate, etc., etc.? You could add things to that, and you don't have to fill in everything. And this is a new pro forma for documenting resuscitation discussions and decisions. It's not accepted nationally. It's not rolled out nationally yet, but it's called RESPECT, and it's called RESPECT not because it respects anything, but it's just a recommended summary plan for emergency care and treatment, including cardiorespiratory arrest. And it's got a section where there's a section where it says, do you want to prioritize sustaining life at some expense of comfort, or do you want to prioritize comfort? And this should not be used in children, because a parent cannot say, yes, I am willing to compromise his or her comfort, or I am willing to compromise his or her lifespan. It should be a medical decision. Therefore, we don't make them tick this. This is for adults. This is what we tick, because this is a clinical recommendation, and whether the focus should be on life-sustaining treatment or on symptom control and comfort. And then whether CPR attempts are recommended, or whether we do modified CPR. Sometimes it's like parents, and we think it is okay to try respiratory pulmonary resuscitation, but not cardiac resuscitation, or cardiac resuscitation short of drugs and things like that. And this page then lists what basis these decisions have been made, whether the child has capacity or whether it's based on best interests. So in summary, sustaining life at all costs may not always be the right answer for every child. And decisions always need to be individualized. As I said at the beginning, there is no right or wrong answer. It depends on the child and the family. And there are many ethical and legal frameworks that will be of use. Early open discussions and planning helps. And if possible, multidisciplinary collaboration, and including parents as colleagues and making it very clear to them that we do value their input as colleagues. Right, I think that's all I have to say. I would really appreciate your thoughts and how this would apply to the context there, or how it doesn't.
Thank you, Archana. It was a very enlightening talk, and actually we gained a lot of points from your talk, especially the way we talk to the parents, like because as you said, when we make a decision, it is just like whether you give in to ventilate or not. Whether you give antibiotics or not give antibiotics, or if you ventilate or not give ventilation. Basically, it should be a physician's decision, not a parental decision. And we have to guide them into what you call a knowledgeable decision. So that, because there are a lot of instances where we give them their choices, but they are really without any knowledge about the how to take up the choices, and that is very important, as you said.
I think one of the important things is they then live with the guilt, thinking, "Oh, we made the decision to switch off the ventilator," which is we should be very clear to them that it's not their decision, and they shouldn't have that guilt. It's a medical decision.
Yeah, well, it was really enlightening, and I'll ask Lulu Madam, is there? Lulu Madam?
I'm here.
Madam, any comment?
Yeah, it was a lovely talk. I enjoyed listening to you, Archana. And I'm really happy that you took up palliative care right at the beginning of your career, whereas I came into
I wouldn't call it beginning, but yeah,
towards the end of my career. That's the difference between you and me. I'm really happy that a youngster like you are working in palliative care.
Not
one thing, when you do BBM, do you do it with an adolescent? Do you do it alone with the adolescent, or in presence of the parents? Breaking bad news.
Yeah, so the vast majority of my patients are neurological patients, so I can't really have those conversations. But I do occasionally have I don't know, sort of neurology, but affecting just the lower limbs, or cardiac, and sometimes cancer. And I do try to have discussions with them separately. I always offer them the opportunity. And many children say, no, I'm happy with mom and dad. But I usually try to engage them in the discussion, even if it's with the mom and dad, and offer them the opportunity to meet separately.
CK sir is there with us, and CK sir.
Shall I speak, Archana?
Yeah.
That was really wonderful.
Thank you.
And the issue that you brought in is in the center stage in our state. And I will say that it was initiated by none other than Dr. Rajagopal.
Yes.
And seasonally he writes an article, especially he's centering around adults. He pleads and he asks, he wrote his own will that at old age, when you are on the last phase of your life, you should have a decent, reasonable exit from the world. I think this is very, very important. There are people who have written their will, but I came to know that that will has no value. It is decided by the place and the doctor who treats him. So it gets prolonged.
Yeah.
It gets prolonged. And you know, the burden on the family is terrific. I had 2 of my classmates who had secondaries in the liver. They were operated and offered everything is fine, dying within 6 months, miserably. The agony they experienced was really terrific. Whenever you go and meet them, they turn your face from you. So I wrote once in your batch, he suffered more complications of the disease than the disease. So this is situation that we face in adults. I don't think it must be quite different in children also, except those morbid situations like chromosomal anomalies and things like that. But things have changed in our own place. I remember as a young pediatrician, when we send a child with Down syndrome to the cardiac surgeon, he said, no, we have no time for that. So many healthy people are waiting, so they come low in the list. But now it is changing. We get so many children with Down syndrome getting operated. So many other groups of children, they get treatment from so many sources. So there is a sudden, I mean, not a sudden, gradual change in the approach as well as the management, acceptance in the society, etc. Anyway, this is really encouraging, and we take a lot of, I would say, clues or tips from your talk. Thank you very much. Please send your mail to me.
I've already sent it in the message.
Okay, thank
you
very much. Very nice to see you.
And Lulu madam too, I tried to email you, but I don't think you got my email.
You give
No, I have not got it.
Just tell her. We'll pick it up.
I'll just put my email here for everyone to see. So.
Okay.
Archana, our Riya sir is here.
Okay.
Riya sir.
Hello. Hello.
Sorry?
Yeah.
Okay.
It's great to see you after a very long gap.
Yeah. Great to see you too.
I remember Archana as a very prolific speaker during her student days. Now she has become an awesome speaker. That's the difference.
Thank you.
Appu eങ്ങനെയുണ്ട് Appu?
Appu സുഖായിരിക്കണോ?
He was very fond. He used to be very fond of Maruti cars when he was a very small kid. ഓർമ്മയുണ്ടോ? ചെറിയ കുട്ടിയാവുന്ന സമയത്ത് he was very fond of cars.
Yeah, he's not interested in cars at all now.
എല്ലാന്ന് പറഞ്ഞിട്ടുണ്ടായിരുന്നു. ചെറിയ കുട്ടിയാവുന്ന ഭയങ്കര ഇഷ്ടമായിരുന്നു. How are your parents?
They're okay. They're not too bad. Yeah, they're in Kochi.
കൊച്ചിയിലാണ്.
കൊച്ചിയിലെ അനിയത്തി കൊച്ചിയിലാണ്. അപ്പൊ അവളുടെ അടുത്തായിട്ട്. She's joined the call. Actually, I can see her name. Thank you so much for this opportunity. This is like, a dream come true, really.
Ashraf.
Thank you, Archana. പിന്നെ രാത്രി അർച്ചന ചിലപ്പോൾ ഡ്യൂട്ടി ഉള്ള സമയത്ത് സാറ് പറഞ്ഞ കുഞ്ഞിനെയും കൊണ്ട് വന്നത് ഓർക്കുന്നുണ്ട് ഞാൻ പഠിക്കുമ്പോ.
ഞാനത് പറയും കേട്ടാ. പേഷ്യൻസ് ഇങ്ങനെ ഭയങ്കര സ്ട്രെസ്, ഫാമിലീസ് പാരന്റ്സ് ഭയങ്കര സ്ട്രെസ്ഡ് ആയിട്ട് പിന്നെ റിയാക്ട് ചെയ്യുമ്പോൾ ഞാൻ പറയും, നിങ്ങളുടെ കുട്ടിക്ക് അസുഖം ഉണ്ട് റിയാക്ട് ചെയ്യാൻ. എന്റെ കുട്ടികൾക്ക് വലിയ കാര്യമായിട്ട് അസുഖമൊന്നും ഇല്ലാണ്ടും ഞാൻ എത്ര ന്യൂറോട്ടിക് ആയിട്ടാണ് പെരുമാറിയെന്ന് എനിക്ക് ഓർമ്മ.
ഒരു ദിവസം രാത്രി 2:30 വന്ന് എനിക്ക് ഓർമ്മയുണ്ട്.
എത്രയോ പ്രാവശ്യം വന്നിട്ടുണ്ട്.
Anyhow, it was a nice talk.
Thank you.
പിന്നെ ഈ ഏരിയയിലെ പല കാര്യങ്ങളും സ്റ്റിൽ ഡിബേറ്റബിൾ ആണ് അല്ലേ?
അതെ. യെസ്.
സാറ് പറഞ്ഞതുപോലെ ഇന്ന് പറയാൻ കഴിയില്ല സർ.
ശരിയാ.
കാരണം പറഞ്ഞാല് പിന്നെ റിയലി ഒരു there are lot of advancement also. അപ്പൊ അത് കോസ്റ്റ് ആണ് പലപ്പോഴും പ്രൊഹിബിറ്റീവ് ഫാക്ടർ. അപ്പൊ കോസ്റ്റ് വെച്ചിട്ട് നമുക്ക് ഒരിക്കലും ജസ്റ്റിഫൈ ചെയ്യാൻ കഴിയില്ല. അപ്പൊ അത് അവർക്കും കൂടി എത്തിക്കാൻ പറ്റുമെന്നാണ് ഇപ്പൊ നമ്മൾ ട്രൈ ചെയ്യേണ്ടത്. എൻസൈം റീപ്ലേസ്മെന്റ് തെറാപ്പി ആവട്ടെ എന്തിലും. Anyhow, it was a nice interaction, Archana.
Thank you so much.
Dr. Geeta,
we take credit for your
Yeah, obviously, yeah, of course.
That you were here with us, so we
Sorry?
get some of the credit for your talk today.
Totally.
And then what is a lot different between the Indian scenario and yours probably is the role of gender. So when we break bad news here and you have the mother and the father, in no way do they expect us to tell the truth to the mother.
Yes.
And it's not just done. Okay. So once I had this horrible experience of breaking bad news to the father regarding a malignancy, and then the mother just walks in and sits down there, and the father says, yes, come. And then I'm totally all at sea because the father knows a lot more than the mother. And then it's a big mess from there onwards. So then onwards, I realized that you need to make sure about the level of understanding of the two people. If at all you are talking to two people together. And I've never ever tried to do that again. So that was a real disaster. And this gender equation in care of children with life-limiting, life-threatening conditions is really something interesting over here.
Yeah, luckily we don't have that issue here. Occasionally I have had South Asian fathers saying, no, my wife won't be able to take it. But, we've said, no, all mothers have to take it, and we'll support her when she needs help. But yeah, it's usually both together, or usually it's just moms, because there will be many single mother households as well.
Okay, Nihas is our dynamic AAP secretary, and anyway, any other comments? If no other comments, we can close the session. Nihas?
Yes, sir. Am I audible? Yes.
Yeah.
Okay.
Audible.
Thank you, Dr. Archana, for coming back to Calicut and giving us a nice session today. Thank you for enlightening up on something which is growing up in Kerala and India. Thank you once again. Thank you, Ajit sir and Mohanda sir, for arranging such sessions regularly and making the IAP a part of it. I also thank our seniors, Dr. Priya sir, Lulu madam, CK sir, who joined us today, and all other teachers, my dear friends and colleagues who joined us today. Thanks, Nabil, for hosting this meeting, and all others who joined. Thank you. We'll meet next Friday with our next session of Meet the Drawings. Thank you all.
Thank you very much, everyone. Thank you.
Thank you, Archana. Bye.